Sorry for the delay, future nurses, but here is Unit 2. We're going to start with theories and therapies. Right, 1956 to 1939. Everything in Freud's thought is that everything happens from our unconscious. These things happened when we were 2 and 3 years old, and it embedded itself in the deepest part of our brain, and it lives there, and that's what causes all the changes in our behaviors. So you have your preconscious, what we can readily recall, so the memories you remember, and the unconscious, the things you don't remember. We watched that quick video. He talked about defense mechanisms. If something traumatic happens, you could go into aggression, and all of a sudden you start acting like a baby and having accidents. His whole idea of therapy is to talk through our emotions and to talk through to try to find what is going on in that unconscious. So psychoanalytical theory and therapy is that patients sitting in the therapist's little bed with their feet up and just talking to their therapist. Interpersonal theory and therapy. Interpersonal theory was started by Henry Stack Sullivan, and this is actually who Hildegard Peplau based her theory off of. And Sullivan says we have a need for interaction, right? We're lonely. Our relationships with our parents is how we develop. So this therapy is good for the short term because it reduces your symptoms by improving interpersonal functions. You develop social relationships. It's good for grief or loss. It's good for like acute psychotic symptoms. So Peplau worked with Sullivan at the beginning of her career, and she saw what he was doing, and she said, hey, nurses can do this too. And Peplau was super important to the nursing movement, though most of y'all have never heard of her besides listening to me talk about her. She changed nursing from, hey, the doctor's telling me to do this, and I'm going to go do something to the patient, to what can we do with the patients. She basically said, nurses were smart. We have the ability to help patients. We have the ability to help patients move forward in their treatment, and we can do stuff with our patient. It's not just turning your patient every 2 hours. Classical conditioning, the dog hears the bell, the dog gets food. And now every time the dog hears the bell, he starts to salivate. Operant condition, it's through rewards and punishment. If you're potty training, right, B.F. Skinner, and your child goes pee-pee in the potty, right, we're like, yay, you did it. You know, here's a star for your sticker chart. And if they have an accident, we're like, no, you don't do that. Positive and negative reinforcement. So behavioral therapy looks at the sole function of there is something wrong with your behavior and we want to change it. Behavioral therapy does not consider the why. So modeling, we see other people do stuff and we use that to fix our bad behaviors, our maladaptive behaviors. Operant condition, we give positive reinforcement to increase desired behaviors, right? Every time that kid goes pee-pee on the potty, they get a star for their star chart, and enough stars they get a prize. They're going to want that prize, so they're going to keep going in the potty. Systemic desensitization, if you're fear of spiders, I'm going to show you pictures of spiders. And little by little, I'm going to be like, here's a fake spider. Here's a real daddy long legs. And finally, I'm going to be like, here's a tarantula. We're going to slowly get used to it. Aversion therapy, putting a negative stimuli with the target behavior. So antabuse is one. Antabuse is a medication for alcohol abuse, and it causes a negative reaction if the patient ingests even a small amount of alcohol. We would tell this patient not even to use hand sanitizer because it would cause headache, difficulty breathing, nausea, and vomiting. So a patient on antabuse, every time they have alcohol, something bad happens, they don't want to have alcohol anymore. Cognitive theory is Aaron Beck, and this looks at that rational emotive. What is going on inside of you? What is happening? What's the event? What are your beliefs about the event? And what are the emotional consequences as a result of the event? So if the event is my friend can't go to a party, that belief about the event, if I don't go and have anyone to talk to, I'll be alone. Our emotion is, I'm going to feel embarrassed and like nobody likes me if I don't have anyone to go with. So in cognitive theory, we replace and reframe those negative thoughts. Maslow's, y'all have probably hopefully talked about Maslow's repeatedly, right? We need air, food, water, shelter. Then we work on safety, right? Do you have a job? Love and belonging. Are you going to be alone for the rest of your life? Or are you going to find someone and fall in love and settle down? Are you going to have a good group of friends? Self-esteem. Do you believe in yourself? And self-actualization. Are you doing everything you can do? So developmental theories, Piaget, dynamic process. We develop certain skills at certain ages, kind of just like everyone else. As we get older, we have more complex thinking. Watched a video in some of y'all's classes. Kohlberg talks about moral development, right? In this level 1, we don't want to get punished, so we don't do stuff. And way down in 5 and 6, we know society has order. We know there's rules and expectations of being a member in society, and we just don't kill someone because we know it's wrong to kill someone. Erikson, kind of just like Freud, will never go away. Erikson's kind of the opposite of Freud. He thought Freud was too negative. Erikson thinks that independence and self-control develops during the early years, right? So especially up to that industry versus inferiority. This is when kids are learning independence. Autonomy versus shame and doubt. Can I do things on my own? Initiative versus guilt, right? Industry versus inferiority. My kids, y'all, are in industry versus inferiority, right? They want to make their own waffles. They want to help mow the yard and do stuff. And they're trying to see, can I do things? Can I be good? And all the way at the end, we get ego integrity versus despair. And at that point in time, adults are looking back and saying, like, was my life good? Was it failure? Or was my life a success? There are different treatment settings in psych. So there's always been a stigma with mental health. Shame, right? Asylums have been around for decades. And it took until 1999 with that Olmsted decision to say, hey, people shouldn't just be locked up in insane asylums. So we have drastically reduced the number of psychiatric beds that exist in America from the 1950s, when there was like 320 some odd thousand in 1950 to like 32,000 psych beds currently. So in outpatient care, we have our primary care provider. They can give medications. However, they don't often have a lot of training, but there's less stigma. So for someone who has maybe like situational anxiety or situational depression, it might not be bad. You have your specialized care provider where you go see a psychiatrist, an APRN, or a therapist, and they have background and training at psych, and honestly, they should be partnering with primary care. Patient-centered medical home is like a one-stop shop clinic. You have your primary care. You have a psych provider. You might even have physical therapy, occupational therapy, all sorts of stuff. You go to one clinic and you get everything. Community mental health, that's like your MHMR, Bluebonnet Trails, home services, emergency services, a lot of community-based services. Like home care, just like everything else, if you need a home health nurse to come change your wound vac, right? Someone who has bipolar, we might send a home health nurse, once a week to see how you're doing and are you taking your meds so we can hopefully head everything off sooner. Assertive community treatment, that's intensive management, and that's usually like a 24-hour on-call for some of your more extreme patients. Intensive outpatient and partial hospitalization, this is someone who they don't need to be in a facility 24 hours a day. However, they need a lot more help than just going to see a provider every few weeks. So these individuals wake up, have breakfast, and go to therapy. They go to groups for either half a day to 6 to 8 hours a day. Emergency care, let's go in the emergency room. And that's super common. It's like a lot of people just go to the emergency room. So there's 3 types of prevention in outpatient care. Primary, right? That's that red ribbon week. Before there is any type of problem, we're going to teach kids that drugs are bad. Secondary prevention are our screenings. Whenever you go to your primary care provider, they should do the audit. And the audit is, hey, how often are you drinking? Because we want to stop you from getting to full-blown, alcohol abuse disorder. And we want to catch an increase in drinking early and prompt treatment because that makes the outcomes better. Tertiary is when we're like, well, hey, you have an alcohol use disorder. Let's admit you to rehab. Let's keep it from getting worse. Let's keep you more stable. So primary is a lot of education. Secondary is a lot of screening. And tertiary is you have the problem. Let's keep it from getting worse. In inpatient care settings, you have a few different types. There's some crisis stabilization, and these are usually 24, 48, maybe 72 hours. Super quick. And then they might send you to something more acute. It's just priority. We're going to just stabilize. General hospital or private hospital, you can have a Dell Children's. Dell Children's has a floor, has a separate unit. That's a pediatric psych unit. Or you can have freestanding like is GBHI. I'm really bad at these, y'all. I'm really bad at accidentally flipping through the slides. State hospitals, that's usually long-term court ordered. So like Andrea Yates, who was found not guilty by reason of insanity, was committed to a Texas state facility. It's essentially you have something crazy going on and you did something really bad, and it's not necessarily jail. You need psych treatment, and you will need it for a very, very, very long time. And honestly, it's usually someone who has like a first psychotic break, something happens, and there winds up being a death. And they wind up spending the rest of their life in a state hospital. So inpatient care, everyone's been to GBHI, 24-hour supervision. Usually, true psych care is locked, right? You can't get out the doors. Addiction and some others sometimes might be unlocked. The patients have rights, right? They can refuse their meds. We have a treatment team. There's a psychiatrist, there's a therapist, they have rec therapy, the people who are listening to the music and dancing and just trying to get the patients doing things. You have the milieu. We want it to be calm, safe, secure. We want it structured. The kids always complain about it. We wake up too early. They wake up just like they do for school. But we follow the same pattern. They should promote a calm and safe environment. The unit designs are always horrible. As I've said in class, I would love to know where these units are. They look so cheery compared to what I'm used to. Like this top left one, the fact that they let them have this cabinet and the hangers and stuff, that is not like psych inpatient. That might be residential or long-term. This is a floor plan where you got, the nurse's station in the middle. Again, that's a great floor plan. I wonder who has it. National safety patient goals. Just like everywhere else, psych is going to follow them. Right? We have some related to behavioral health, though some of the ones related to behavioral health cross over to medical. Identify patients correctly, use 2 identifiers, use medicine safely, prevent infections, and the more psych one, identify patient safety risks. We want to reduce the risk of suicides. What can we do? Right? We're going to take our stuff, we're going to search, we're going to make sure there's nothing dangling from the ceiling for ligature risk. Specialty treatment settings, you have pediatric specific facilities, you have geriatric specific facilities, and there are VA. The Veterans Affairs has a ton of specific psych facilities. So culture. Cultures are beliefs, our values, the religion, the geographic area, right? Austin to El Paso, even though it's in Texas, has a huge difference in culture. What's the language? What's that nonverbal language? We talked about some examples of culture, right? Just super easy. Eastern culture, right? Family. There's a lot of group decision making. Western culture values individuality more. While indigenous culture looks at community, right? So we need to be familiar on different types of cultures, regardless of test or no test, because we need to know how to treat our patients. There are some barriers, right? Verbal communication, different languages. We have to actually use the language line, right? We have to try to talk to our patients. We have to be respectful of their nonverbal communication. If someone's not making eye contact, we don't want to force them to make eye contact. There's a stigma within culture. So we have a giant across the board stigma associated with mental health. But then in certain cultures, it tends to be worse. Cultures with high stigma may somatize their feelings, right? So kind of just like with pain or headaches, you might have an individual who is super stoic and they're like, yeah, my pain's really high. And we're like, well, it doesn't look bad because, right, let's face it, as nurses, we do that all the time. There's no way your pain is this. However, they might be internalizing it. So we have to realize that everyone's pain is different. And we have to be respectful of that because expressions may be unique. Populations at higher risk for mental illness. Immigrants, right? There's a language barriers. They're trying to get used to and adjust to a new environment, and that's hard. Refugees or immigrants who are fleeing their homeland. They don't necessarily want to come. It's against their will. So you have the same struggles as your traditional immigrants when you're talking about refugees, but now you're adding in the trauma due to what happened from the war, from whatever persecution. So you have a lot of stress and anxiety in both of these populations. Cultural minorities, right? There's bias, there's discrimination, there's racism. And that highly affects mental illness, and we need to recognize that as nurses and be prepared to adjust our care for our patients. So cultural awareness, we need to understand that there's 3 cultures: the patient's culture, our culture, and the environment. A psych unit is going to have a different culture than a med-surg unit, which is going to have a different culture than L&D. And even amongst themselves, L&D units, depending on where you go, are going to have different cultures. We always have to learn and continue to educate ourselves, and we have to avoid stereotyping. Meeting individuals who are different than you can help build your confidence as a nurse as you learn things. Legal and ethical decisions. A lot of these are things you've learned before, right? None of this is new. Ethics, what's right or wrong. Bioethics, what's right or wrong in healthcare. Beneficence, do good. Autonomy, right? You can make your own decisions. So a patient, even if they are on a notification of emergency detainment, they can say, no, I don't want to take their meds. Justice, we're going to treat that little old lady whose husband just died and she's really sad the exact same as that meth dealer. Fidelity, loyalty. If you tell a patient you're going to come back, hey, I'm going to come check on you in 30 minutes, you have to actually go back. Veracity, be truthful. If the patient asks, does my med have any side effects? We say, nah, Haldol's great. There's no issues. We're not telling the truth. So we have a code of ethics. I would honestly recommend any nurse read it. I just always like to highlight we have the same duty to ourselves. The American Nurses Association say we have to promote health and provide care to our patients. We have to respect the individual uniqueness, worth, and dignity of our patients, and we have to do it to ourselves. No admission. A voluntary admission is someone who comes in and says, hey, I want to die. I'm having these thoughts of suicide, and they sign themselves in. Involuntary is a judge or a police officer says, hey, this person needs to be there. And usually an involuntary admission is going to be 72 hours. It gives us 72 hours to evaluate the patient and see what's going on and do our best. Assisted outpatient treatment, the court says, hey, look, you need to go to addiction. Addiction gets a lot of court order treatment. Conditional release, you can be discharged. However, you have to continue to go to outpatient care. If you don't go to outpatient care, we will come and admit you again. Unconditional release, bye, it's so nice to meet you. Release against medical advice. If someone's stable and they're like, look, I want to leave AMA, and you're like, we were probably going to discharge you tomorrow anyway, we can let them leave AMA. But if you have a patient who's psychotic and suicidal and they say they want to leave AMA, we could seek an involuntary commitment, and then they don't get to leave. Patients have a right to treatment. They have a right to refuse treatment. However, a violent patient who's a danger to themselves or others, though I don't like the word chemical restraint, we have the right to override we as healthcare providers have the right to be safe. So if a patient is refusing their medications and they get violent and they assault staff, we will restrain, seclude, and we will give you medication to calm you down. You can also have a court order to force schedule medications. But that actually is like a huge packet of paper where we take it to a judge. Patients have a right to informed consent. and they have a right to privacy. And it gets tricky sometimes because, we're going to search through patient stuff. We're going to search through some of the family stuff. And they're like, don't you search my stuff. However, because we have that duty to keep everyone safe, we're still going to search through stuff. So psychiatric advance directive. We should always ask if someone has an advance directive, but then it gets tricky because if someone's psychotic, they can't sign their advance directive. So we have to follow up with family. Restraints and seclusions only in an emergency situation. You cannot have a standing order to restrain PRN. It does not exist. Every time a patient has to be restrained, it is a separate individual order that we have to call the provider or talk to the provider if they're there. And we have to get that order. And we always want to try that least restrictive intervention. Manual hold, right? We're just going to hold you. Mechanical hold, we're going to tie you down. That does not happen often. Chemical restraint, right? That's knowing someone. I'm going to give you so much meds that you're just going to pass the F out. However, never, ever, ever document chemical restraint because no one does chemical restraints. We give medications to help with anxiety and agitation. And then seclusion, I'm going to put you in a room and I'm going to close the door and leave you there. Confidentiality. We've kind of talked about this before. We have ethical responsibilities. So the patient must give us consent to release information. However, if the patient's reporting abuse, or we have a duty to warn if they are reporting that they're going to leave here and go kill their husband, we have a duty to break that confidentiality when it comes to child abuse or a threat to someone else's life. Different types of restraints. Laws: assault, threatening someone; battery, touching someone; false imprisonment, inappropriate seclusion or restraint. So if you have a patient who's refusing medications and we don't have any court order, they're not violent or aggressive, and you seclude and you restrain them to give an IM injection, and they are not being violent, they are not threatening to hurt themselves, they're just refusing medications. That's one, false imprisonment because we restrain them without a need, and then battery, giving that IM injection because we touched a patient, right? That nurses, way back in the day, back in my day when I started as a nurse, we always used to tell patients, you take this pill or I will give you a shot. That is assault. You cannot say that. Intentional negligence. We need to be that perfect nurse, and they're going to look and say, what would that perfect NCLEX-ruled nurse do? If you didn't do it, that's negligence, right? Super easy example. If you have a patient who, right, you're doing geri care and she's in bed and all of a sudden you're like, oh my gosh, she just pooped. Shift change. I don't want to change her diaper. And you just let her sit in her own filth until next shift comes. That's negligence. So malpractice, you have a duty. So we have something we're supposed to be doing. So we're supposed to be rounding on our patients every 15 minutes. There's a breach of duty. We say, I'm too busy. I'm not going to round right now. I'll round in 30 minutes. Cause and facts and proximate causes are honestly kind of the same thing. Both must be present. And that's kind of, did you not rounding cause the damages? So the damages, if we don't round on a patient every 15 minutes and the patient kills themselves, their death is the damages. So we are looking at, would the patient have been dead if we would have rounded? So if it's like, the patient very much could have killed themselves in between rounds, then we might not prove cause and fact. But you need duty, breach of duty, cause, and damages to claim negligence. Documentation, right? Accurate and complete. We have to document what's happened. We have to document in a timely manner. We have to document subjectively, right? Patient states pain is 7 out of 10. And we have to document objectively. Patient is sitting in bed, playing on phone, eating dinner, watching TV, and talking to people, but states pain 7 out of 10. Okay, psychobiology and pharmacology. I'm going to blow through a lot of this stuff in the beginning because it's hopefully common knowledge, right? We talked about the brain. It does all of the things in our body. When it doesn't do it, we see dysfunction in all of the areas, right? Alteration in reality, that's the definition of psychosis. Difficulty with interpersonal relationships. You have a ton of neurotransmitters. We watched the super tiny video, right? Serotonin, happy, dopamine, pleasure, endorphins, right? Exercise, excitement. And honestly, we have it in the next few slides too, right? 90% of serotonin is made in the gut. Why? We see GI side effects. Dopamine. Too much schizophrenia, too little Parkinson's. That's why we see those muscle and the movement side effects from antipsychotics. Norepinephrine is fight or flight. GABA works a lot with anxiety. Glutamate, learning memory, so we see that in Alzheimer's. Right, that brainstem, that's your primitive, you're breathing, you're sleeping. Hypothalamus, hunger, thirst, sex are basic drives, thoughts, and emotions. Cerebellum is honestly that roadside sobriety test. Voluntary motor movements, equilibrium. Cerebrum, looking at the world around you. Can we communicate? Can we perceive the world? So there's MRIs and CTs, which we can see the brain, but then also a PET scan. And PET scans are super cool. Just go and Google PET scans mental illness, because you can see changes in the brain, right? You see that normal brain looks different than the mild cognitive, which looks much different than Alzheimer's disease. So when we talk about psychotropic drugs, and honestly any medication, pharmacodynamics, what the drug is doing to the body. So it's going to affect your serotonin. Pharmacokinetics, how it works through the body. It's metabolized this way, it's excreted this way, it gets absorbed this way. Pharmacogenetics. If your mother was stable on Lexapro and you have the exact same problem, let's give you Lexapro. But also like carbamazepine, Tegretol, we have to do genetic testing on individuals of Asian descent because they have a huge increased risk of Stevens-Johnson syndrome. So anxiolytics, hypnotics, and sleep aids. I can go for some of these right now, y'all. Benzos. They promote GABA. GABA is calming. They, on their own, are not really going to cause respiratory depression, but they're scary when they're combined with like alcohol, COPD and sleep apnea even, things that are causing respiratory problems. So we have to be careful. Opiates, right? Because they interfere with motor, ability, attention, and judgment. These are used for acute anxiety. If you are terrified of enclosed spaces and you need an MRI, I can give you a benzo, and it's going to work wonderfully because they only work for a few hours. They do work on everyone, so they're wonderful. However, the fact that they only work for a few hours, someone with chronic anxiety keeps taking more and more and more and more and more, and they wind up addicting. Buspar is wonderful because it's less addictive than a benzodiazepine, right? Honestly, there's no risk of addiction or dependency with Buspar. It doesn't have a sedative effect, and it's given scheduled usually. I have seen it PRN, but it works better scheduled. Take it every day. It will help calm you down, and it can work in the long term for long-term anxiety. And antidepressants, SSRIs and SNRIs, are wonderful for anxiety. Hypnotics, right, these are your Z because they have a Z, Ambien, Sonata, Lunesta. They're the sedative effect without any other things. Basically, they can cause amnesia because you just go to sleep and you forget, and they work fast. However, there's a difference between tolerance and dependence and habituation. You tend to see habituation with these medications. I really need to take it. If I don't take it, I cannot sleep. So the patients become dependent upon it to sleep, not quite addicted. You see a lot of sleepwalking, eating, and driving without them knowing about it. And that's what makes it dangerous. A lot of weight gain just because of the sleep eating. Melatonin, naturally occurring hormone, doesn't have abuse potential. Works fairly well for some people. Doxepin and Belsomra, sorry y'all, I can't do these names. These work to keep you asleep. So these are for individuals who maybe wake up. They work better for that. Antidepressants. Ton of stuff with antidepressants, right? Your SSRIs. They keep your SSRIs keep your nerves from absorbing serotonin, so it increases the amount of serotonin in your synaptic cleft. SSRIs are our first line for almost everything because you have less anticholinergic, less sedating side effects. They work for anti-anxiety, right? Low libido, GI upset, nausea, vomiting, and your anticholinergic still can happen. There's a list of some of the approved SSRIs. Paroxetine, Paxil is the specific one we're talking about. Most anticholinergic though. And we have to be concerned if we're giving something that's anticholinergic if someone is contraindicated, as in narrow angle glaucoma. Not on your slide, and I wish they would have put it there, is serotonin syndrome. Serotonin syndrome is a honest-to-God, real, true emergency. And it happens because the patient's like, hey, 1 paroxetine is good, 2 medications is even better. So they might not tell a provider that they're starting on a new medication. So it might be like, let me go get some phenelzine, let me go get some paroxetine, and let me take both. Sometimes providers just don't write the orders well, and they might just wind up on 2 SSRIs. But serotonin syndrome can cause death. And also not on these, I hate your slides. We have to be cautious because taking an SSRI or taking any antidepressant increases the risk of suicide. Our patients are so tired and they have no energy, right? They're out of spoons, that even though they want to die, they don't have the strength, they don't have the spoons to kill themselves. When we give an SSRI, they take sometimes 4 weeks, 2, 3, 4, 6 weeks to work. And at that 2-week point, they have more energy, so they're waking up with more spoons, but they're still depressed. So they are able to kill themselves. There is a black box warning, especially for pediatric patients and SSRIs. Actually, any antidepressant. So there's a whole bunch of different types of SSRI, other types of antidepressants. Norepinephrine, serotonin specific, right? Remeron helps with sleep. Wellbutrin and Zyban, bupropion, works with smoking cessation. We have to be cautious because it does lower the seizure disorder. So we have to be careful with alcohol or sedatives. There's a lot of these, right? Trazodone is one of my favorites. We use it a lot for sleep. Anticholinergic effects causes priapism. We always seem to forget that, but it does happen. Rexulti is a new one. And we give that with depression for schizophrenia. Trintellix we see a lot, more so in geriatrics because it can help with cognition. NRIs, right? So we have SSRIs, we have SNRIs, and there's a billion other little classes of antidepressants. Effexor, Pristiq, right? Venlafaxine, desvenlafaxine, duloxetine. These can help with neuropathic pain. They can help with depression treatment and anxiety. Because we're affecting serotonin and norepinephrine, we see more side effects. So this is a great second line. They work well in anxiety. They work well for depression. And sometimes we'd give these if for whatever reason maybe an SSRI doesn't work. Vibrid, it's an antidepressant and anti-anxiety. Cause GI upset just like everything else. Take better with food. Tricyclic antidepressants, these are a lot of your tryptamines, triptyline, amitriptyline, nortriptyline, prototriptyline, empyramine, I can't say all these, y'all. They were our first line before the invention of SSRIs. However, right, SSRIs could take 4 weeks to work. These are going to take 6 weeks, and they're lethal in overdose. So our patients have no energy. We start to give them energy, and now they have the energy to kill themselves. If you give them a 30-day supply of tricyclics and they take all of them, they are now dead. And that's because they're cardiotoxic. So we really have to be cautious of that lethal in overdose. MAOIs, right? Tyramine is broken down in the liver. MAOIs affect tyramine in the body. The biggest thing, MAOIs are an antidepressant just like everything else. And we have to be cautious because if the patients eat any of these food, right, the charcuterie board, the salami, the pepperoni pizza, the caffeinated coffee, the chocolate, the sour cream, right, there's so many different foods patients can't eat. And if they eat those foods, it causes a hypertensive crisis. Again, we also have to be concerned with what else are they taking because we don't want to take an MAOI with another antidepressant. So like phenelzine is a type of MAOI. So we need to be extremely cautious not to take phenelzine and any other type of antidepressant or any other type of MAOI. Right? Nardil, Parnate, Marplan are some of the other ones. Mood stabilizers and anticonvulsants, lithium. One of our first, it's a salt. Right? Extreme alterations in the lithium level cause convulsions. Fluid imbalance is huge because it's a salt. So we have to maintain their fluid and sodium intake. We have to keep it normal. If your patient's all of a sudden like, I'm going to drink 3 gallons of water today, we're going to be like, no, because that's going to lower their lithium level. And then at the same time, if your patient gets a stomach bug and they have nausea and vomiting, they're going to get they could potentially get dehydrated, and that could increase their lithium level. So we have to be careful, right? 0.5, we see mania. 0.5 to 1.5 is therapeutic. Above 1.5 is toxic. Our first sign of lithium toxicity is nausea and vomiting, right? So 1, the first sign of lithium toxicity is nausea and vomiting. And 2, nausea and vomiting can increase our lithium levels. So we have to be concerned about nausea and vomiting. And then we also just need to make sure our patients are getting their blood drawn, because if you get to that like 2.5 and 3, we got cardiac issues going on. Anticonvulsants, Depakote, Tegretol, Lamictal, the most important thing is that they're hepatotoxic. We have to be monitoring our liver levels, our AST, our ALT, our lipase, right? We got to be monitoring it. Why are we talking about anticonvulsants in psych? Yes, we see seizure patients. However, these can also be used for mood disorders. So let's say someone can't take lithium. We can try Lamictal, Tegretol, or Depakote, right? So besides that liver toxicity, besides the fact that we can use them for mood disorders, we have to be concerned about Stevens-Johnson syndrome. I hate looking at these pictures, not my type of nursing. However, Stevens-Johnson's is a serious side effect, and though it can happen with a bunch of things, it does tend to happen more often with the anticonvulsants. We're almost done, y'all. 10 more slides. Antipsychotics. Too much dopamine, psychotic symptoms. So we want to block the dopamine, right? So positive symptoms are delusions and hallucinations. So our old school, first generation or typical, has more of effect on delusions and hallucinations. However, dopamine plays a role in a movement. So side effects of these medications include muscle and motor abnormality. So we'll talk about EPS, dystonia, Parkinson's, and tardive dyskinesia. We have to monitor for involuntary movement. We use the AIMS. However, it can also cause amenorrhea, galactorrhea, and gynecomastia. So we got to watch out for those. So pseudo-Parkinson, right? That's your Thorazine shuffle. They're stooped over. They're not even like lifting their feet. They're just shuffling along very slow. They're shaky, and they got that pill rolling. Acute dystonia is facial grimacing. Their eyes, right? Involuntary upward eye movement, that's an oculogyric crisis, and the eyes are actually stuck looking at the ceiling. They cannot move their eyes down, and you basically get muscles that contract and don't uncontract. We'd have to be concerned about laryngeal spasms, right? And these happen a lot with our old school antipsychotics. So like Haldol, haloperidol is one of the most common ones we still use, right? Honestly, one of my favorites is still Thorazine. You see that occasionally. Akathisia is that restlessness. You have a patient who's anxious, we give them Haldol and we want them to calm down, and all of a sudden they're restless and have this uncontrollable urge to move. And we're like, oh my gosh, what happened? They physically cannot sit still. Even if we were to get them to sit in a chair, their feet would still be moving. That's akathisia. Tardive dyskinesia is probably one of the worst because it can be permanent. Once this starts, if we don't stop it, it just keeps getting worse. And that's the protrusion rolling of the tongue, right? Facial dyskinesia, at least in my brain, is weird movements, chewing motion, sucking, smacking of the lips. So we have to be mindful of tardive dyskinesia. We have to report, honestly, all of these to the providers, but especially tardive dyskinesia. So in the first generation, you also see anticholinergic, orthostatic hypotension, sedation, and weight gain. Neuroleptic malignant syndromes on another slide for some reason, And neuroleptic malignant syndrome is an all of a sudden high fever. Your patient isn't sick. They just have a 104-degree temperature. And they're a little confused or a lot confused. And that we just have to get the temperature down. There's not much else we can do. Second generation or atypical antipsychotics, these are newer ones. We got the names on the slide. They affect serotonin and dopamine. So it works with delusions and hallucinations, but also those negative symptoms, the anhedonia, right? Inability to feel pleasure, inability to be happy, the lack of socialness, the lack of motivation. These are first-line treatment because the side effects aren't as bad and because they help the positive and negative. However, we see metabolic syndrome, increase in weight, blood glucose, triglycerides. Clozapine and olanzapine are the worst. Abilify and Geodon are the best, which is honestly why you see Abilify so often in pediatric patients. So these second generation, there's a few, right? These are all of them. Clozaril is amazing. It works so well, but we don't use it because of the risk of agranulocytosis. So we can make our patients neutropenic with this medication. So they'll present with like a low fever and sore throat. And we're like, nope, hold the med. Let's get labs. Let's see what's going on. We have to be drawing labs regularly. Risperidone is long acting. It's the highest risk of EPS in the second gen class because it has a better effect on dopamine. Seroquel, sometimes we see it for sleep or just anxiety. Moderate risk of weight gain and metabolic syndrome. And then Zyprexa, highest risks of a lot of these things that I've seen even in pediatric patients. New onset type 2 diabetes after starting olanzapine. So we have to be cautious. Here's some more. There's a bunch of them. A lot of meds can cause QT prolongation. We want to do an EKG ahead of time, right? Think about your nursing functions. Latuda is specific to must be taken with 350 calories or else it doesn't work. This is that metabolic syndrome, right? It causes neuroleptic malignant syndrome. It can be confused with serotonin syndrome or an anticholinergic crisis. We see altered mental status and a high temp in neuroleptic malignant syndrome. And then, right, QT interval, we got Q, we got T, and T keeps running away from Q. ADHD meds. ADHD meds are like giving your patient meth. They work with norepinephrine and dopamine. However, agitation, psychotic thought, hypertension, growth suppression, potential for abuse. Today was my school nursing day, and I had this little kid came in, and I was giving him his ADHD meds. And he's like, if I don't take this for a while, I can feel my heartbeat really fast, and it feels kind of weird. And then out of nowhere, he's like, it also doesn't make me hungry. I go sit at lunch, but I don't want to eat lunch. All honestly, side effects of it. We see growth suppression. We have to monitor the patients. We have to make sure they're eating, and sometimes we stop giving it over weekends and holidays from school. There are a bunch of non-stimulant ADHD meds, Strattera, Intuniv, and Catbay. Intuniv and Catbay, right, guanfacine and clonidine, these are traditionally blood pressure meds, but they work well with kids. We just got to watch the blood pressure. And the non-stimulants are great because there's this potential for abuse in both the kid and in the parents. Alzheimer's, you don't have enough acetylcholine, so the meds work on cholinesterase. So it stops the cholinesterase from breaking down the acetylcholine, which increases your acetylcholine. Biggest thing to be careful about with these is, right, we need to give them early. We cannot give this to someone with severe Alzheimer's. It's going to slow the process, but not stop it. Herbal treatments, not everything is safe. We have to be looking at what our patients are on, right? You see all sorts of crazy things. St. John warts, you honestly can't take with anything. Ginkgo biloba and warfarin causes bleeding. Especially psych patients, pediatric patients and their families, a lot of times we have to get that family list and we have to be looking up to see why they're taking it and is it actually safe and is it what they say they are. Gas station testosterone is scary. Simple Nursing has a bunch of videos. However, also in your Canvas course, you have a ton of resources. You have a bunch of practice questions, right? You got that pre-test, you got that post-test. You also have a bunch of activities on theories, on the different types of medications. So you can go ahead and do all of those to help you study. If you have any other questions, let me know.